Okay, so please do not make noise now. So let's start. So today's topic is neonatal jaundice, a very, very important one. Last time we talked about neonatal resuscitation. Another important topic in neonatology is neonatal jaundice. Okay, so let's move further. So I want to start with a case. Okay, now see this. Let's quickly go through the case and then uh, let's enter into the topic. This is a patient profile here. Okay, the baby's name is always kept after mother's name at the time of delivery. So I've written a baby of Mrs. Young. This is a second para mother, and the blood group is O positive. O positive blood group. This is important one. Date of birth here. Look at the time. This is important. 12:50 p.m. Okay, 12:50 p.m. And this is the way we write the diagnosis of the newborn. Full term, FT is full term, S is single, a singleton, M is male, this is the sex of the baby, AGA is appropriate for gestational age. Okay, appropriate for gestational age is AGA. So appropriate for gestational age is AGA. So some students are kept on talking, so I mute all of you. Okay, so let me finish it, then probably I'll allow you later on. Appropriate for gestational age means the weight at the time of birth, okay, is between 10th percentile to 90th percentile. If any weight falls between this range, then we call it appropriate for gestational age. And NVD is normal vaginal delivery, which is delivered in the hospital. This is the way we write the diagnosis of the newborn at the time of birth. So you have to make a practice of this. Birth weight of this baby is 2.9 kg, and the baby was admitted. See here, this time is important. The baby was admitted next day at 12:30 p.m. The baby was delivered at 12:50 p.m. So within 24 hours, the 24 hour is not passed. The baby is still in the first day of life. The baby was admitted in the hospital. Okay, probably the baby is still in the hospital, right? It's not discharged, but the baby probably was with mother, but now the baby is admitted in a special ward. That is the meaning. Now why? Because the baby has developed yellow discoloration of body at 22 hours of life. That's why the baby was admitted. On further questioning, the baby was sucking mother's milk well. There was no history of any fever, no vomiting, and the baby has already passed stool 3 times. Okay, during examination, baby looks very yellow, and urine was also passed. So stool and urine passed within 24 hours in this baby. That is good thing. Regarding the perinatal history, okay, the perinatal period starts from period of viability, that is from 22 or 24 weeks of gestation till 7 days after birth. This is called perinatal period. So when we ask the perinatal history, there is Apgar score of 7/10 at 1 minute and 8/10 at 5 minutes. Okay, even if they don't write 1 minute and 5 minutes, you have to understand that if they give these two value, the first one is at 1 minute, the another one is at 5 minutes. So this baby was fine at the time of birth. Apgar score looks quite healthy. Regarding the labor and delivery history, it was unremarkable. Okay, it was unremarkable. There was no problem. No maternal illness was found during pregnancy, and there was no history of diabetes mellitus. These are important history for neonatal jaundice. That's why we have asked this. No maternal drug history. Very significant. We always ask this question. And the family history of jaundice is always asked. So in this case, there was no family history of jaundice. No history of any splenectomy. Now, you have studied before in hemolytic anemia, one of the treatment is splenectomy, but there was no such history in this case. That means no hemolytic anemia was running in the family. There was no early gallbladder disease. Remember, gallstone can be caused by hemolytic anemia. So these are the indirect question. and there was no jaundice noted on previous baby also. She is a second parity mother, isn't it? So previous baby was also fine. Now, as a doctor, you have examined this baby. So you have found the baby is quite active, alert, and the baby is a tom baby. Okay, the baby is full tom baby. There was icterus up to the sole. Okay, icterus was present up to the sole. That means baby was severely jaundiced already. The vital signs are within normal limit. Respiratory rate is 48 per minute. Normally, it should be less than 60, so it is normal. Heart rate 130, which is also normal, and temperature 37 degrees also fine. Now, this AF is anterior fontanelle. Anterior fontanelle is at level, which is also normal, isn't it? Anterior fontanelle should be at level. And capillary refill time is less than 2 seconds. Okay? Capillary refill time is less than 2 seconds. This is also normal. Capillary refill time should be less than 2 seconds. Okay? So this is also normal. Now see here, the weight of the baby was 2.9 kg. Okay, at the time of birth. OFC is occipitofrontal circumference or head circumference is 34.5. And during 5th semester, I clearly taught you what is a normal OFC or head circumference. It is 35. So it is near to the normal. We take it as a normal one. Length is 49. Normal is 50. So it is also considered normal here. There is no history of any bruising or no cephalhematoma or no finding, I should say, because we are examining the baby. So no finding of bruising or no cephalhematoma present. Okay? Cephalhematoma can also lead to jaundice. That's why it has been examined. The hydration status was maintained. The baby was not dehydrated. Tone and reflexes are normal, and all the systemic examination is within normal limit. Okay? All the systemic examination is within normal limit. Okay? Now see here. Okay, now see here. So we are examining the baby now. So they have done total serum bilirubin at 23 hours of life, and that total serum bilirubin is 22.3 milligram per deciliter. So the normal total serum bilirubin should be less than 5. Okay, it should be less than 5 in the neonate. If it is less than 5, there is no jaundice, but it is 22.3 there, so it is very high. Baby blood group A positive, mother's blood group was O positive here, so it's not matching. Okay, baby admitted in neonatal unit and phototherapy started. This is the treatment of jaundice, and breastfeeding was advised every 2 hourly. Now, what the doctor did in the hospital, you need to know that they have repeatedly done total serum bilirubin at 60 hours. It is 19.6 now. It is slightly dropped. Direct Cum test was done. This is negative, and this direct Cum test is mainly done for autoimmune type of hemolytic anemia. Okay, so it was negative here. Okay, it was negative. Osmotic fragility test was normal. So this is not a case of hereditary spherocytosis. G6PD test was also normal. Okay, G6PD test was also normal. So this is not G6PD deficiency. They have done peripheral smear which shows normocytic, normochromic RBCs and no features of hemolysis. Reticulocyte count was 5%, and this strongly tells us that hemolysis is going on there. Okay, this tells us hemolysis is going on inside the blood. Hemoglobin was already dropped to 13.6. Okay, this should be gram. Okay, you need to correct it. This should be gram per deciliter, and platelet count is within normal limit. Look at TSB or total serum bilirubin at 72 hour. It further increases now. At 66 hour, it was 19.6, and at 72 hour or 3 days of life, it reaches to 26. So it is increasing. Now, what have they done further? Phototherapy was already started, so it was continued. The baby remained quite active during that period. Baby was sucking well on the breast. There was no dehydration, no fever, and stool and urine was passed normally. But the icterus gradually reduced from soles to face now. Because of this phototherapy, probably this is the treatment of jaundice, so it gradually decreases. That is a very good point for the baby. Now, on day 6 of hospital admission, the total serum bilirubin was dropped to 14.4 milligram per deciliter. Okay, so it is decreasing. Packed cell volume was 40%, and they have discharged the baby with final diagnosis of ABO incompatibility. So this is neonatal jaundice with ABO incompatibility. Now, why this term has been given? Remember, what is the blood group of the mother? It was O positive, and blood group of the baby was, okay, isn't it? It's a different one. So it's not matching. So this is known as ABO incompatibility. And this can also result in neonatal jaundice. So this is the way cases should be prepared and presented to your senior in neonatology. Okay, this is what I want to teach you. So with this, let's start our class of neonatal jaundice. Now, jaundice is a clinical condition characterized by yellowish discoloration of sclera, mucous membrane, and other body parts due to accumulation of bilirubin. Now, jaundice is also known as hyperbilirubinemia. That means there is excessive deposition or accumulation of bilirubin in certain areas of our body, which results in yellowish discoloration of sclera or mucous membrane. Now, in comparison to the adult, the neonatal jaundice is slightly different. Now, what's the difference here? You need to know that. The clinical jaundice in the neonate becomes apparent only when serum bilirubin concentration is more than 5 milligram per deciliter. In adult, if it is more than 1 or 2 milligram per deciliter, they look slightly yellow, but in newborn, it should be more than 5. And this neonatal jaundice is very common in the normal newborn. It's almost present in more than 2/3 of the normal newborn. 65% means almost 2/3 of the babies. Okay, now let's talk about bilirubin metabolism. So I have muted you, but if I ask some question, you can unmute yourself and answer. Okay, please remember that. Yeah, because there's a lot of noise coming, so we have to do this. Now here, how bilirubin is produced, how bilirubin is synthesized or formed. Now the source of bilirubin is RBC. Okay, when RBC is broken, okay, when RBC is broken, then bilirubin is formed. When RBC is broken, or especially when the hemoglobin is broken, hemoglobin is present inside the RBC, so it's the same thing. Okay, from the heme, bilirubin is formed. Okay, one of the metabolite is called biliverdin, and from biliverdin, with the help of biliverdin reductase enzyme, bilirubin is formed. Now this bilirubin will bind with albumin and it is going towards the liver. Now, what is happening there? Okay, let's talk about it. See here, inside the blood, the bilirubin is formed already. This is unconjugated bilirubin because conjugation occurs inside the liver. This unconjugated bilirubin, let me use some of the highlighter so it will be easy for you to note it. Okay, yes. So this unconjugated bilirubin combines with albumin, and this goes towards the liver. When it reaches hepatic sinusoid, only the bilirubin will enter into the liver and albumin remains outside. Now this bilirubin will be conjugated. Okay, the bilirubin will be conjugated. Now can you tell me which enzyme is that which conjugates the bilirubin? Anyone? Very good. Very good. Very good. This is glucuronide transferase or UDP, glucuronide transferase. Excellent. Okay. You can unmute yourself now. So after this bilirubin will be excreted in the biliary tract or in the biliary system. Okay. And through that biliary tract or biliary system, the bilirubin or conjugated bilirubin will go towards the second part of the duodenum because the common bile duct opens there. But inside the intestine now, there are bacteria which are normal flora. These bacteria have protease enzyme, so this bacteria will break down this conjugated bilirubin, and some of the conjugated bilirubin will turn back into unconjugated bilirubin, and some other will turn into urobilinogen. Now, around 10% of the urobilinogen will be reabsorbed back into the portal circulation and reach to the blood again or towards the liver, and other 90% will be excreted in the feces. But there is one extra thing which is forming in between. Urobilinogen will turn into stercobilinogen, then stercobilin, and that stercobilin will be excreted in the fecal matter. Now, one very important point here, the color of the feces, that slightly yellow color of the feces, is because of this substance known as stercobilin. Okay, never forget this. Now, what happens in obstructive jaundice? If there is complete blockage of the bile duct, no bilirubin is passing into the small intestine, what would be the color of the stool in that case? Yes,
Clay color.
Clay color stool.
Pale, pale,
very
pale
good,
color.
very good. It is called clay color, or you can also say very pale looking stool. Okay, clay color or very pale looking stool. Excellent. Now the urobilinogen, which is reabsorbed back into the circulation, will be excreted through the kidney into the urine. So urobilinogen is excreted into the urine. So if you know this much in the metabolism of bilirubin, we have done well. Okay, so it's the same slide, slightly shown in another way. So you can go through this on your own. The same, exactly same thing. Now after this, let's talk about what is the etiology of neonatal jaundice. What are the causes? Very important question from the exam point of view. Now we have divided this into early jaundice and late jaundice. Okay, and this is the boundary, before 10 days or after 10 days or after 2 weeks. Now in that category also, if jaundice occur in the first 24 hours of life or in the first day of life, it is always pathological. We have to consider it very seriously. And the common causes of jaundice in first day of life are immune hemolysis. Okay, immune hemolysis. See here, okay, immune hemolysis. Isn't it? It's very clearly written, means RH incompatibility and ABO incompatibility. A case of ABO incompatibility just shown to you, but RH incompatibility is even more, okay, common than ABO incompatibility. In this case, mother is RH negative and the baby is RH positive, but nothing happens probably during the first pregnancy. Okay, from the second pregnancy onward, there will be a serious problem in the newborn. Now, another cause of jaundice in first 24 hours of life is non-immune hemolysis. Look at, these are hemolytic anemias, G6PD deficiency, okay, pyruvate kinase deficiency, and congenital spherocytosis. Okay, you can list some other hemolytic anemia as well. G6PD deficiency is X-linked recessive disorder. So this is seen only in male baby. Never forget this point, only in male baby. Regarding the sepsis, the intrauterine infection or TORCH group of infection quite commonly lead to jaundice in first 24 hours. So this is TORCH group of infection, toxoplasma, rubella, cytomegalovirus, herpes simplex, and if I add S here, that would be syphilis. If I don't add S, then this O stands for others. Okay, other. So in that other, you can write syphilis there. So both are correct one. So let me erase this first, and then we go to the another slide. Okay, fine. Now see here. Now after 24 hours, what are the causes of neonatal jaundice? Okay, let's talk about it. Physiological jaundice is the main thing after 24 hours. This is very common. Okay, almost 2/3 of the baby after birth develop physiological jaundice. Physiological means we don't need to scare from this. But if it is very high, we need to measure what is the bilirubin level. If that bilirubin level is more than 15 milligram per deciliter, we need to admit that baby in the hospital for phototherapy. If it is lesser than that, you don't need to do anything. Just ask the parents to expose the baby in sunlight. Okay, the sunlight will decrease the jaundice. Now, another condition which causes jaundice after 24 hours is excessive bilirubin production because of this different mechanism, like bruising. Okay, bruising means collection of blood clot. Okay, because of blunt trauma. This bruising may be because of birth injury or birth trauma, which mainly occurs on the scalp of the baby. Cephalhematoma. You already learned what is cephalhematoma in 5th semester. Okay, this is a collection of blood clot, isn't it? In the scalp area. DIC, a disseminated intravascular coagulation, intraventricular hemorrhage, polycythemia, where this excessive RBC, and even ingested maternal blood that can happen during delivery. Okay? The maternal blood can be ingested during delivery. Okay, 1 minute. Some of the students want to join here. Okay, fine. Okay, see there. So ingested maternal blood also can produce excessive bilirubin. So these are some of the causes. Now, third one may be infection. The same torch group of infection may lead to jaundice, and sepsis. This is a sepsis after birth, which also leads to neonatal jaundice after 24 hours. Another is congenital non-hemolytic hyperbilirubinemia. Now, these are the congenital condition, and these are not hemolytic anemia, like Crigler-Najjar syndrome, Gilbert syndrome. Okay, these two are quite familiar name. We are not new to this term. Gilbert syndrome and Crigler-Najjar. Even in medicine, you have heard this. So, in both of these conditions, there is problem with that UDP glucuronide transferase enzyme. Crigler-Najjar is very serious disorder. Gilbert is a very, very benign one. Metabolic disorders like galactosemia, okay, it also leads to jaundice, and some of the congenital hemolytic disease which can lead to jaundice in first 24 hours of life can also lead after 24 hours. The same condition like G6PD deficiency, pyruvate kinase deficiency, and congenital spherocytosis. Okay, let me erase this, otherwise it will cause a bit of problem for us. Fine. Now, what are the causes of jaundice after 10 days? After 10 days, if the jaundice develops, or if the jaundice remains for more than 10 days, which is called prolonged jaundice, what may be the cause? Now, I have divided this under two different headings: prolonged unconjugated hyperbilirubinemia and prolonged conjugated hyperbilirubinemia. So let's talk one after other. So this jaundice is caused by breast milk, which is known as breast milk jaundice, because in the breast milk there is inhibitor of glucuronide transferase present. But frankly speaking, many baby, they don't develop any breast milk jaundice, but few of them may develop. So we cannot guarantee which babies are developing that. Okay, so you don't need to stop breastfeeding after breast milk jaundice. But if jaundice is excessive, if the baby needs to be admitted in the hospital, then for a short duration we may stop breastfeeding. Otherwise, there is no need. The same sepsis, if it persists for a longer duration, will lead to prolonged jaundice, and some of the metabolic condition. Among them, hypothyroidism is the very, very important one. Okay, others are quite rare: galactosemia, fructosemia, and cystic fibrosis. These are not common disorder, but hypothyroidism in the newborn may be very common. Okay, so why? The question is why it leads to prolonged jaundice, and the answer is we need thyroid hormone, that is T3 and T4, for the maturation of that enzyme. Again, that enzyme is glucuronide transferase. That means the glucuryl transfer is immature. It cannot function properly, which leads to prolonged jaundice. So one lesson you have learned from this class: if a baby develops jaundice for a longer duration, the jaundice has appeared quite early, but it has not disappeared, don't forget to order thyroid function test, or TFT. And we all know what is TFT, isn't it? T3, T4, and TSH. So you need to order those. Other mechanism may be increased enterohepatic circulation. Okay, the bilirubin is revolving between the liver and intestine. This occur in these following conditions, like intestinal obstruction. Okay, nothing is passing beyond, so the bilirubin is getting absorbed and recirculating. Pyloric stenosis, same type of condition. Intestinal atresia. Okay, the intestine is not formed properly. Hirschsprung's disease, where there is colon, one segment of the colon is not formed, it is not contracting, it is acting like a obstructed segment. Meconium plug and ileus, the meconium is hard, it is blocking the flow inside the intestine. So all these can increase enterohepatic circulation and lead to jaundice. Now this is very easy for you. Hemolysis can lead to jaundice in any period of life, within the first day, in second day of life, after that, and even after 10 days, and even in the adult. So similar type of conditions are written here. Vitamin E deficiency can lead to hemolysis, because vitamin E is a non-antioxidant. If that is deficient, then the particular child or adult can have hemolysis. Okay, now the another part is left behind. This is prolonged conjugated hyperbilirubinemia. Now let me repeat a little bit here. Inside the liver, the unconjugated bilirubin will be converted into conjugated one. Then only, remember that, then only that bilirubin can be excreted in the bile. Without the conjugation reaction, bilirubin is no more water soluble, and water soluble bilirubin, okay, is only present in the bile. The unconjugated bilirubin, maybe a small amount is present, but it is not a significant way of excretion. So in neonatal hepatitis, okay, there is conjugated hyperbilirubinemia, and these are the cause of neonatal hepatitis. You just need to remember the term neonatal hepatitis here. Okay, let's not complicate the things. These are all the very rare condition which can lead to neonatal hepatitis. Mostly it is idiopathic and caused by infection. Now another easy mechanism you need to understand is bile duct obstruction. If common bile duct or intrahepatic ducts are blocked, then hyperbilirubinemia will occur, and that hyperbilirubinemia is conjugated type. The common causes are biliary atresia, okay, choledochal cyst, which is a bit rare, ascending cholangitis. There is ascending type of infection which is going from the intestine and climbing up towards the liver, okay, and bile duct stenosis may be some other cause. Now there is one autosomal dominant condition which is a very rare, known as Alagille syndrome. In Alagille syndrome, there is paucity or lack of intralobular bile duct. Now what will happen? If bile duct are lacking, that means the conjugated type of bilirubin cannot flow towards the intestine, which can lead to conjugated hyperbilirubinemia. So very easy explanation there. Now we are moving on to the very clinical part of this topic. Okay, always this is one of the content in my teaching, because we are going to be a doctor. When I start working in the hospital, if I don't know how to take history, okay, it will be a real problem. So how to take this history in a case of neonatal jaundice? See here, history of present illness should be asked in detail, like what is the age of the baby? We always ask this question. What is the sex of the baby? If the sex is male baby, probably G6PD deficiency may be the cause, but other so many causes are there. Okay, when jaundice was first noted, In first day of life, after first day of life, okay, or later on? Very, very important question. If it is noted in the second day of life, the most common cause is physiological jaundice. Was the baby term or preterm? Important question. Preterm baby have higher chances of neonatal jaundice than term baby. What is the birth weight of the baby? Important question. If the birth weight is more, okay, if the baby is large baby, then there is a high chance of neonatal jaundice, because large baby usually suffer from polycythemia. They usually suffer from intrauterine hypoxia, and intrauterine hypoxia can lead to polycythemia again. Okay, is the baby sucking well? Very important question, because sick baby has higher chance of jaundice, and sick baby will not suck well on mother's milk. What is the color of stool and urine? Many students have already answered to me. In case of obstructive jaundice, the color of the stool is pale or clay colored, but the color of urine is high colored, because the conjugated bilirubin will be excreted in the urine. Okay. What is the frequency of stool and urine passage? Now think about intestinal obstruction. Think about those diseases which were listed. They can cause increased enterohepatic circulation, and that can lead to excessive jaundice. Ask about history of fever, vomiting, and abdominal distension. They are very common in sepsis, and neonatal sepsis is a very important cause of neonatal jaundice. At the same time, in horse-sprung disease, in intestinal obstruction, or in pyloric stenosis, vomiting and abdominal distension are quite common, but there is usually no fever. Ask about whether the baby has seizure or not, and seizure in case of neonatal life is a feature of neonatal sepsis again. Does mother think baby is sick? Especially this question is important if the baby is delivered at home, okay, or if the baby is already with mother, because mother's observation should never be ignored. Okay, mother is always right, we say. So this is very important question. Okay, fine. So let's start again. We are talking about what are the important history we should take in a case of neonatal jaundice. Now, in case of labor and delivery history, you need to ask whether there is any instrumental delivery or not, like vacuum or forceps delivery, because they can lead to trauma on the scalp, which can lead to cephalohematoma and then neonatal jaundice. Use of oxytocin can result in neonatal jaundice. It is said that because of displacement of bilirubin from the albumin site, the jaundice can be there. Asphyxia is a very important cause of neonatal jaundice, and delayed cord clamping as a result of more blood flow towards the baby. It may be a cause of polycythemia, which can result in jaundice. So look at the importance of taking labor and delivery history. We always ask about maternal history of fever, illness, and history of maternal diabetes. Now, this maternal diabetes can be of two types. One is gestational diabetes, which is developed during this pregnancy, and another, she may be diabetic from before. Okay, both are important points. Now, regarding the family history, I have already talked a lot before. We should ask about history of jaundice in family, anemia, if runs in the family or not, any history of splenectomy or early gallbladder disease. All of them denote hereditary hemolytic anemia, which runs in the family. So who knows, this newborn may be having the same or similar type of disorder. This liver disease can also run in the family, okay, as a different hereditary condition: galactosemia, tyrosinosis, alpha-1 antitrypsin deficiency, Gilbert syndrome, Crigler-Najjar syndrome, and cystic fibrosis. Many of these metabolic disorders are run in the family because of autosomal recessive way. Okay, autosomal recessive way. This is how we remember. Ask about history of sibling with jaundice who need phototherapy. Okay, before, for example, brother or sisters who are elder than this baby, Who knows? Those babies were also needing phototherapy at that time. Any history of exchange transfusion or anemia. These are a very, very good clue to this baby. History of consanguinity. Consanguinity is marriage between close relative. Now, during my classes or lectures, I have told this many times. Autosomal recessive disorder are quite common in consanguineous marriage. All the autosomal recessive which are listed here. Okay, so this is a good question to ask. Now, after finishing history, let's examine this baby. What are the important points? It always start with general appearance, whether the baby looks sick or active or healthy. Measure the vital signs in the newborn, the 5 vital signs. Okay, the 5th one is pulse oximetry. All others are very familiar to you. How far the jaundice is there? Okay, how far the jaundice is there? Now, how to measure it? How far the jaundice is there? Okay, let's go to the next slide, and I'll come back after a while. See here. Now look at this picture here. This baby is completely yellow. Okay, the face is yellow. Okay, the chest looks very yellow. And look there. This is the way to note jaundice. We just give a form, push by our finger, and you can stretch the skin also. If it looks yellow, then this is jaundice. Okay, if it doesn't look yellow, the jaundice is not there. So these are a quite important point. And at the same time, you can press on the sole also. If sole are yellow, that means jaundice is already reached to the sole. That means this jaundice is severe, maybe more than 15. Okay, this is another slide which is telling the same. See here, if jaundice reaches sole, that means jaundice is more than 15. If it is still present in the head area, okay, still present in the head area or the face area, it is still within 5 milligram per deciliter. If it is reaching till the umbilicus level, it is 10. If it reaches till the knee joint, 12. And if it reaches till the lower limb or till the foot, but foot are not yellow, then 15. And if foot is also yellow, or if feet are yellow, I should say, it is more than 15. So this is one of the very good clinical estimation of neonatal jaundice. This roughly matches with the TSB level. Okay, now let's go back. Whether the baby is premature or not, we need to examine. Premature baby have high chance of neonatal jaundice. I already told you. Okay, small for gestational age or SGA babies have very high chance of jaundice because probably they already suffer from intrauterine infection, and because of intrauterine infection, they are smaller. So intrauterine infection can easily lead to neonatal jaundice. And these babies are usually hypoxic as well. Hypoxia can lead to polycythemia, and because of excessive RBC, it can easily lead to neonatal jaundice. So listen to the explanation which I am giving. Okay, this is very, very important for you. Check for microcephaly. Okay, microcephaly may be associated with a lot of syndrome, and those syndrome are associated with neonatal jaundice, and sometimes even small for gestational age or premature baby are microcephalic. Dysmorphic face, a perfect example is Down syndrome. Okay, face doesn't look normal, you have to examine that. Multiple congenital abnormality, whether it is present there or not, we need to make sure. Okay, we need to examine that. Extravascular blood in the form of cephalhematoma or bruising, I told this already. This is an important cause of neonatal jaundice, so make sure it is not there. How pale is the baby? It denotes probably hemolytic anemia as the cause of jaundice, because in hemolytic anemia, jaundice and pallor goes together. Check for petechiae and purpura in the skin. These may be the feature of bleeding disorder like DIC and some other type of bleeding disorder. Okay, so these are important physical examination. Let's move further. I've already dealt with this. Let's go to another slide now. Now, what are the criteria for pathological jaundice? how can I say this is not a physiological jaundice? Because physiological jaundice is not that scary, but pathological jaundice, the bilirubin can become high within a short period of time. Okay, so we need to make sure whether this is pathological or physiological. So these are the points. If jaundice appear in first 24 hours, it is always pathological. It's never physiological. It's a very easy point. Second one, what is the rate of rise of the jaundice? Okay? How quickly the jaundice is rising. So increase in level of total bilirubin by more than 0.5 milligram per deciliter per hour, or if it is more than 5 milligram per deciliter in 24 hours. For example, in first day, okay, it was 5. In second day, it reaches 10. In third day, it reaches 15. Like that, then also it is pathological. Total bilirubin more than 15 is always pathological. I've already told you. We do not ignore this. This baby should be admitted and then treated. And if direct bilirubin, okay, if direct bilirubin is more than 2 milligram per deciliter or more than 15% of the total serum bilirubin, then also it is abnormal. Okay, then also it is abnormal. Now, what are the investigation we like to order in the case of neonatal jaundice? Let's talk about it. Now, those investigation should start with total serum bilirubin or TSB, isn't it? That is the first thing. Now, with total serum bilirubin, okay, direct serum bilirubin is always done, and indirect serum bilirubin or unconjugated bilirubin we calculate. If we subtract direct from the total, indirect will come. What is the blood group of the baby, and what is the cum test status of the baby? We should go for this. Now, direct cum test is positive in case of autoimmune hemolytic anemia. Autoimmune hemolytic anemia. I have muted you all because some of the students, they never listen. Okay, they are making a lot of noise. That's why. Now, the third one, blood grouping and antibody screening of the mother should be done. We should know what is the RH status of the mother, whether she is RH negative or not. Is there any ABO incompatibility or not? Okay, that is very important knowledge. And what is the antibody screening of the mother? If antibody test comes positive in the mother, we call that indirect cum test positivity. So I think I have explained this before, okay, in my prior lectures. Don't forget to see peripheral smear of RBC morphology and reticulocyte count. They are abnormal in hemolytic anemia. Reticulocyte count is always high in hemolytic anemia. Okay, it is usually high in hemolytic anemia. Check about hematocrit as well as hemoglobin level. They decrease in hemolysis. Direct bilirubin is always examined. And one important point, if direct bilirubin is higher, it shows this is a case of obstructive jaundice. Okay, there is some obstruction to the bile flow. If you suspect G6PD deficiency in a male baby, go for the screening. Do G6PD screening and you will get the diagnosis. And if that baby is sick, if you think baby is septic, go for CBC or complete blood count, blood culture and sensitivity, urine routine examination and culture and sensitivity, chest X-ray as well as CSF analysis. This is done by lumbar puncture. So see there, this is a full septic screening. I have done CBC with blood culture, urine routine examination and culture, chest X-ray and CSF analysis. And if the baby is septic, we will find out after this test comes back from the lab. Now, what are the other investigation we like to do? Okay, what are the other investigation we like to do here? Okay, see this. Now, in prolonged jaundice, LFT or liver function test, torch screening, and VDRL screening. This VDRL screening is done for syphilis. sepsis. Okay, thyroid function test, I've already explained this point to you. Any other metabolic defect like galactosemia. In galactosemia, there is appearance of galactose in the urine, and galactose is a type of reducing sugar. So these are some of the important points. Check about the blood sugar, and blood sugar may be decrease in case of infant of diabetic mother. Okay, it is decrease, it is not increase. Hypoglycemia is very common in infant of diabetic mother, and infant of diabetic mother has very high chance of jaundice. Examine prothrombin time and other like APTT, okay, fibrinogen level and all those things. If you suspect DIC, and try to diagnose extrahepatic biliary atresia and choledochal cyst by doing ultrasonography of the abdomen. If necessary, go for CT scan as well. So these are some other investigation to find out what type of jaundice is there, whether unconjugated or conjugated. Now we have come towards the last part of this lecture, that is management, but which is very, very important from the exam point of view. Not only from the exam, okay, from other aspect also. If you want to be a good doctor, these are absolutely important point. Now the first type of management we do is phototherapy. Okay, phototherapy. Now how this phototherapy helps and how we do it. Okay, so listen carefully. In phototherapy, the baby is completely naked, and this nude or naked infant is kept about 45 centimeter from the light source. Okay, it is 45 centimeter. So this distance is very, very necessary. Otherwise, if it is lower than 45, it will give too much heat to the baby. The baby will be heated up, and if it is a bit far away, it is not effective. The type of light here is called blue light, and this has a spectrum of 420 to 460 nanometer. This is called wavelength of that blue light. Okay, this is necessary. And when we uh, uh, give phototherapy, we need to cover eye and genitalia. Cover eye and genitalia because they will be damaged by the persistent exposure to the light. Okay, this is important point. For the maximum area of exposure, we need to frequently change the position of the baby. Frequently change the position of the baby so that it will be highly effective. And meanwhile, we need to measure whether our phototherapy is effective or not by sending total serum bilirubin to the lab. If it is declining by 1 to 2 milligram in 4 to 6 hours, that means you are doing good job. The phototherapy is helping the baby. Okay, these are some of the important points. Now they may ask you, what are the untoward effect or some unwanted side effect of the phototherapy? Those are loose green stool, dehydration, hyperthermia or increased temperature, and bronze baby syndrome. Now this bronze baby syndrome means this baby, okay, especially if they have more of conjugated type of bilirubin, then that conjugated type of bilirubin may turn into bronze color, which is called bronze baby syndrome. And that's why only unconjugated bilirubin or hyperbilirubinemia is treated by phototherapy. Okay, conjugated bilirubin is not decreased by phototherapy. That is not the treatment. Actually, we should find the cause for that and go for the management. Now look at this picture here. Okay, see here. So this is the very nude or naked baby. Okay, the genitalia and the eyes are covered. This is very important one. And the distance between this blue light, okay, source and the baby's body should be 45 centimeter. This distance is 45 centimeter, and this is a blue light which you can clearly see. And for the very good type of management, we need to rotate the side of the baby. For example, after a few minutes, you should turn the baby to the other side. Okay, maybe left side, right side, or on the back. and this is the effective phototherapy. Now this is not important for you, okay, at this stage. This is a little bit difficult. This table tells us that what is the level of bilirubin at which we go for particular treatment. Now see here, if uh, if the bilirubin level is more than 15 in 25 to 48 hours of life, you go for phototherapy. In more than 72 hours of life, if bilirubin level is more than 20, then you go for phototherapy. So this is one good guidelines for us. If bilirubin is very high, you can consider exchange transfusion if phototherapy fails, and exchange transfusion is always necessary at this level. Look at the level of bilirubin here. In second day of life, the bilirubin is more than 25. We can never ignore this. This bilirubin can seriously damage the brain. So exchange transfusion with intensive phototherapy is necessary. Okay, this is the meaning of the table. And this is for the preterm infant now. Okay, similar type of explanation for the preterm infant. Remember, the level for preterm infant would be much lower than the term baby, because the blood-brain barrier of the preterm infant will develop much later than the term. So even the lower level of unconjugated bilirubin can be entering into the central nervous system through blood-brain barrier. Okay. Now, what is the concept of exchange blood transfusion? Why exchange blood transfusion is one of the management in case of hyperbilirubinemia treatment, and when we go for it. Now, I like to highlight a little bit important point in the beginning. Now, sometimes what happens, this jaundice is caused by antibody. These antibodies are binding with the RBC and they are causing hemolytic anemia. Now, there should be a certain management where we remove all these antibodies and damage RBC as well at the same time and replace new RBC to the baby. This is called exchange blood transfusion. Okay, now you already got the meaning. So it is most effective and reliable way to reduce serum bilirubin level when it reaches the critical level in the baby. It is done via the umbilical vein or umbilical artery. Umbilical vein is more commonly used. It removes anti-D antibody. Now this anti-D antibody means anti-RH antibody. Okay, so the common term is anti-D antibody actually than anti-RH antibody. It removes not only those antibody but also the RBC which are coated with antibody. So this is a very effective therapy. It really helps the baby. Okay, it corrects anemia as well because you are giving new RBC from outside. The person who has a matching blood type should donate the blood in this case. And the infants who are complicated by all of these different type of pathology like hypoxia at the time of birth, hypothermia, metabolic acidosis, hypoglycemia, sepsis, and if is there any effect of drugs in the system, then this infant will receive exchange blood transfusion at lower serum bilirubin level, because all of these pathology will combine with hyperbilirubinemia and brain damage can happen even at lower serum bilirubin level. So we don't wait for that particular level. The commonest indication of exchange blood transfusion is rapidly rising bilirubin in first 24 hours of life, and these days the number one indication for exchange blood transfusion is RH hemolytic disease of the newborn. Okay, never forget this question. RH hemolytic disease of the newborn means mother is RH negative, baby is RH positive. This is the number one indication for exchange blood transfusion. Now look at this picture here. Okay, this picture is telling us, see here, this baby is very yellow. okay, very yellow baby, and look at the catheter here. This catheter is inserted into the umbilicus through the umbilical vein, and we are first drawing the blood from the baby, okay, and that blood is discarded outside, and after that we push the new blood to the baby's body. That's why it is known as exchange blood transfusion. Okay, so this is highly effective therapy for the treatment of neonatal jaundice. Now we are towards the end. What are the early indication of exchange blood transfusion in Rh hemolytic disease? In which condition we go for it quite quickly? We don't wait any longer. The first indication is if cord hemoglobin is 10 gram per deciliter or less. Now remember, at the time of birth, the hemoglobin in the baby is very high. It is about 18 to 20 gram per deciliter. If it has already fallen to 10, we can't wait any longer. Hemolysis is quite severe. Another, if cord bilirubin is 5 milligram or more, that also means the destruction of RBC is occurring quite quickly. The third point, if unconjugated serum bilirubin is more than 10 milligram per deciliter within 24 hours, or 15 milligram per deciliter within 48 hours, or the rate of rise is more than 0.5 milligram per deciliter per hour, then also you have to go quickly for exchange blood transfusion in case of Rh incompatibility. Now, what are the complications of exchange blood transfusion? Isn't it? It is just like, very advanced type of therapy. So definitely it has certain complication. This is infection. If you do not take safety precaution, then infection can enter into the body of the baby, and that is quite hazardous. Hypothermia, because the baby may be exposed for a long time, so hypothermia may occur. And if you give relatively cold blood, then also hypothermia can occur. Hypoglycemia is also very common side effect, or I should say complication. Cardiovascular instability may occur because you are giving fresh blood from outside. If the amount of blood is high, if there is a more plasma rather than hemoglobin, then that can happen. Electrolyte disorders like hyperkalemia or hypocalcemia can occur very easily or commonly, okay, because this potassium can be released from those RBC. Some of the RBC, if they are old, they will be hemolyzed very easily. Complication of catheter may be there. One of the very important question you will be asked in future exam is portal vein thrombosis is associated with exchange blood transfusion during the neonatal life. Now see there, this is the damage done to the umbilical vein because of that catheter, and later on that baby may develop portal vein thrombosis. Okay, and inadequate exchange is always a complication. Maybe because of some complication, you have abandoned the procedure in the middle, and that is not helping the baby, because baby needs exchange transfusion to treat this severe jaundice. Now I'll make this as a last slide for today. These are the supportive therapy which are important in neonatal jaundice. One, adequate feeding should be continued. Okay, the breastfeeding should be given if the baby can feed on the mother's milk. If not, probably IV fluid or other way of feeding. Treatment of sepsis, if the baby is septic. If CBC is abnormal, if blood culture is positive, I should always treat with antibiotic. Correction of acidosis, okay, go for the cause of acidosis first, and then if necessary you need to give sodium bicarbonate as well. Phenobarbital, remember this is a sedative and hypnotic drug, but this phenobarbital is a very important inducer of cytochrome P450 enzyme system, and this UDP glucuronide transferase is a member of that system. That's why phenobarbital, by inducing that hepatic enzyme, is helping to resolve, okay, unconjugated hyperbilirubinemia. So in the exam they may ask you this name of the drug. Which drug you want to use? It is phenobarbital. Remember this. But some side effects would be there. The baby will be very sleepy or drowsy. If cephalohematoma is causing this neonatal jaundice, we should go for aspiration. If it is quite big enough, then only go for it. Otherwise, it will be more harmful for the baby because you may introduce infection. Avoid vitamin K in large dose. Okay, vitamin K is usually given in case of complicated babies after birth because they need vitamin K injection. But this vitamin K may aggravate jaundice. Another point, exclusion of lactose and fructose from the diet when galactosemia and fructosemia are suspected because they may harm. Okay, so these are excluded. And one important substance, the drug known as albumin, can be given. Remember the metabolism of bilirubin here. What happens to the unconjugated bilirubin after production? It will bind to the albumin. So this is the logic why we give albumin in the treatment of unconjugated hyperbilirubinemia, and that is given in the dose of 1 gram per kg of 5% salt-free albumin 1 hour before the exchange transfusion, and this achieves 50% more effective exchange by removal of bilirubin. It really helps the exchange transfusion in a better way. Okay, so this is one of the option. Okay, now at last we talk about bilirubin encephalopathy or kernicterus. Now, acute stage of kernicterus is also known as bilirubin encephalopathy. Now, what is this? Now, remember, this total serum bilirubin is mainly unconjugated variety in this case. In case of newborn, whatever causes are there, okay, the most common type I'm talking about, that is unconjugated hyperbilirubinemia. That unconjugated bilirubin can cross the blood-brain barrier, especially if that baby is sick or ill because of sepsis, okay, or because of any other causes like CNS infection may be there sometimes hypothermia may be there, sometimes acidosis may be there. All these will, cause easy entry of that unconjugated bilirubin into the brain. Okay, because blood-brain barrier integrity will be altered. This can occur even easily in case of preterm babies. That's why in preterm or premature baby, even if they are having much lower level of unconjugated bilirubin or total serum bilirubin, okay, if they are sick, we should do early exchange transfusion or early phototherapy. Now with this knowledge, let's go into the topic. It is a neurological syndrome due to deposition of unconjugated bilirubin in the basal ganglia and brainstem nuclei. Especially the basal nuclei or basal ganglia region is affected. They will get stained or they will get damaged by bilirubin. Now this usually occurs in first week of life, and it really depends how high is the serum bilirubin. I already told you, in a relatively normal baby, the serum bilirubin level should be very high to have kernicterus, but if they are relatively sick or ill, then even at relatively lower level of bilirubin, kernicterus can happen. Now the pathogenesis is multifactorial. We need three things together. Look at this triad here. Total serum bilirubin is one, maturity of that baby is another one. In premature baby, it has more chance of development, and integrity of blood-brain barrier is the third thing. The blood-brain barrier is intact, which happens in a healthy term baby, probably the chance would be less. But if it is already changed or altered because of some ongoing diseases, then the chances are quite high. Now, what will happen to the baby in kernicterus or bilirubin encephalopathy? Now, we divide this into two forms, acute and chronic. Now, acute form again divided into three phases: phase 1, phase 2, and phase 3. In phase 1, there is poor sucking from the mother's breast, stupor or extreme drowsiness. Now the baby develops hypotonia, a decreased tonicity of the muscle, and seizure. Phase 2, after a few days, hypertonia of the extensor muscle will develop now. There may be arching of the back, which is called opisthotonous position, and baby may be slightly febrile. And phase 3, again hypotonia, stage would come back. Now, chronic form, if that baby survive, become a bit older child. During first year, hypotonic feature, okay, would be there, but if we examine the deep tendon reflex, they are exaggerated or active, and this baby will have delayed motor skill or delayed developmental milestone. This is the origin point about kernicterus. And after first year of life, there may be movement disorder, different types of involuntary movement may be there. The baby may have a upward gaze or abnormality in the gaze, and even hearing loss, that is sensory neural hearing loss. Now, what can we do to prevent from this kernicterus to happen? Now, remember those guidelines which we discussed before. Uh, if those guidelines are met, then we have to go for early phototherapy and early exchange transfusion. These are the only way to prevent against kernicterus development, especially if there is active hemolysis going on, okay, like RH incompatibility or any other hemolytic disease. Or sometimes if the baby is sick, okay, even with a lower bilirubin level, we have to think about doing phototherapy and exchange blood transfusion early, so that the baby will not get kernicterus. This is a very, very important point, because kernicterus can lead to all those problems which are just listed. Okay. Now, at the end, please go through these questions which I have collected for you. Okay, confidently solve them, and then you think you have done the good job. Thank you very much.